for public comment. We do have a sign up in the room, and we're going to go over a new public comment policy here soon, so just be aware of that. But for now, it's the same, so you can send me a message in the chat, raise your hand when we get to public comment. We'll make sure we capture you. Today, Dr. Marshall is out, so Dr. Ott will be fearlessly leading us today. And so I will turn it over to her shortly. Just a reminder, we're still doing the roll call vote. So when we get to a vote, you can do aye, nay, or abstain. And we will start us off with the call to order and remarks of the chair. Dr. Ott.
Thanks, Amanda. So I will call this June 2024 meeting of the DUR Board to order, and I have no further comments.
All right, that takes us then to opening comments from OMPP.
Obviously, I'm not Leslie Lugo, so our fearless leader is out of the country at the moment. That's something she wants to be. They didn't kick her out. So otherwise, we don't have any comments. We'll be talking about pathways here in just a little bit.
All right, that takes us then to approval of the minutes, Dr. Ott.
Do I have a motion to approve the minutes for May 2024?
So motion by Chris Johnson.
Is there a second?
Second, Pat.
Amanda?
All right, we have a motion and a second. So Dr. Ott.
Aye.
Dr. Klaas.
I'll abstain. I wasn't there.
Okay. Ms. Fippen.
Aye.
Mr. Johnson.
Yes.
Dr. Simon.
Aye.
Dr. Treadwell.
Aye.
All right, we have all ayes and one abstention, so that motion will carry. Thank you. We will then move into our update of the PA stats for May of 2024. So as you can see, overall, we had just a little shy of 20,000 approved, which was 71%, and just a little over 8,000 denied, which was at 29%. When we look at our point of sale quick check, we had 73% approved and 27% denied. Of those that were denied, 22% went to the call center, where 77% were approved and 23% were denied. On the manual PA side, we had 59% approved and 41% denied. So I think it helps to look at our trending graph just to see that everything's been really, really steady since pretty much January, February timeframe. So holding pretty steady each month right now. When you look at our top 10 PAs, overall stimulants, opioids, and antipsychotics in the top 3, which is pretty much what we've come to expect here for quite some time. And then on the top 10 manual PAs, we had early refills, quantity limits, and the Mental Health Quality Advisory Committee utilization edits. The early refills are down a little bit from where they were last time, and you might remember we had them increase a little bit, we think, due to spring break and maybe some of the disaster recovery things that were happening. So that's come back down in the month of May. Any questions on those before I move into the opioid statistics?
Hey, Amanda, no question, but it's coming over a little ringy as far as the microphones on there. Are you speaking at a distance from the microphone or something close to you?
I'm speaking from a distance, so does this sound ringy right now?
It's very echoey. It's like you're in a canyon. I don't know if the other board members hear the same, but it's sometimes a little distorted.
Is it better now?
That's much better.
All right. I'll put on my radio voice, my radio DJ mic. All right. So for the opioid statistics, we did have a slight increase in the total utilizers, very small, and then a decrease in our new utilizers. Our under 18 are about the same, increased a little bit in their average day supply, but still under 5 days. So about what we would expect to see there. You can see to the right the breakdown between the less than 90, which is where the bulk of our members are, and then so on up the line. Just of note, the greater than 500, we don't have any utilizers that are not PA exempt. So those that are getting through the benefit all have exempt PA. When we look at our graph, this is the 90 and above, so you can see still pretty small numbers and nobody in the 500 and higher. And then when we look at our overall trending, fairly steady from where it's been last month and kind of what we've been seeing sometime. Again, the green is the current utilizers over 18, the cranberry is the new, and then the purpley blue at the top is the current utilizers less than or equal to 18. Here's our overall trending. So you can see the less than 90 MME is increasing slightly, which again, we've got very small numbers. So it just could be people that are cycling through. And then here's our 90 and above. You can see that the 250 to less than 500 did go up just slightly. Again, this is such a small number that it could just be a couple of patients. So it's something we'll continue to monitor. The 200 to 250 did stay fairly flat or go down maybe a little bit, so it may be a shift there. Overall, nothing alarming or nothing that we wouldn't expect to see right now in these graphs. Any questions or concerns on the opioids?
Hey, Amanda, Chris Johnson again. Question on the numbers that you show there with the breakdowns between the various MMEs. Are we excluding any cases like for cancer pains or things like that that would might skew that?
Yeah, so that's the PA exempt numbers to the right. Those are the individuals that have a diagnosis of cancer, sickle cell, or other end of life that we can track. Yeah.
Good. All right. Thank you.
Mm-hmm. Any other questions? All right. That takes us then to the next agenda item, which is any update from the managed care group. I'm getting head shakes of no, so I will assume we are good there. I will then turn it over to not Leslie Lugo because she is out of the country, but to whoever is presenting the Pathways for Aging program, which appears to be John Ross because he looks like he's shuffling papers. So John, I will turn it over to you.
Thank you, Amanda. Yes, I am John Ross. I'm with the pharmacy team, and I'm just kind of going to go through the Pathways program and its impact to the pharmacy benefit. So if you watched more than a few hours of network television in the past month, you will have seen the Pathways commercial.
True story.
They are wearing me out. Pathways for Aging is Indiana's brand for MLTSS, which is Managed Long-Term Services and Supports. It is set up to provide services for Medicaid-eligible Hoosiers 60 years and older. Those services include acute preventative care, home and community-based services, and nursing facility services. Next slide. Enrollment started in June, in March, so it's ongoing right now. The managed in MLTSS is administered by, or will be administered by 3 MCEs. 2 of them you're very, very familiar with. Anthem, whose pharmacy director continues to be Amy Berger, who's here, and United Healthcare, whose pharmacy director is Monica Blankenship, who is also in the room. The third is a new player, Humana. The pharmacy director is Bill Porch, who is in Florida, attending his, oh, is he on? Okay. Hi, Bill. I'll let you introduce yourself in a second, but he is in Florida attending his son's wedding, as I understand it. And also throw in that Lisa Peru is also on the call in case we need 2 players to move in up for that. So, Bill, Melissa, do you have anything to add as far as Humana's jumping into the fray with Medicaid?
Morning, John. No, just really looking forward to this opportunity to help take care of these Pathways members. And we're just getting ready now for the July 1st go live date.
Very good. And I don't know if you 2 wanted to say anything or, yeah, okay. You know them, and there's really nothing on their end that's going to change except for they're going to have a few more members. So there are about 124,000 current fee-for-service members that will move to one of the 3 MCEs for this program as of July 1. I will throw in that you'll notice that the age for pathways is 60 and above. So when they are 65 and older, they are automatically Medicare eligible. And so the vast majority of their drug therapy is covered by their Medicare Part D plans. We basically only supply things like over-the-counter drugs. The only group that is going to be significantly impacted for the short term would be the 60 to 64s, who will obviously be using our pharmacy benefit. And again, though, it's the same benefit that they've been used to under fee-for-service. If you, in your free time, if you want to peruse the Pathways website, it's displayed here. Next slide. So this slide displays sections of Indiana law pertaining to the pharmacy benefit and how our program and MC contracts are set up to follow that law, or those laws. The fee-for-service and MC pharmacy benefits are aligned under SUPDL. The drug classes not listed on the SUPDL, we call them neutral drugs because they are not impacted by the SUPDL, are managed by the MCEs, but subject to review by ONPP pharmacy team. Under IC 1215-35.5, fee-for-service regards mental health drugs, also called the AAAX drugs, as all preferred, and the MCEs must align how they manage these drugs with the fee-for-service program, which they have been doing. Next slide. Okay, so this law requires MCEs to submit their initial formularies to this esteemed body so that you can confirm that the MCE's pharmacy programs are meeting the following requirements, assuring that their programs won't impact quality, won't increase cost of the program, provide their members access to a minimum of 2 drugs in each class, provide access to all medically necessary drugs, and meet the legal requirements of the Indiana Department of Insurance. Next slide. The ONPP pharmacy team has set up provisions in the MCE contracts and work with the MCEs so that board can be comfortable confirming that the MCEs meet these requirements. So the MCEs are aligning with and will continue to align with all board-approved fee-for-service SUPDL and mental health drug managed care policies. The MCEs will submit policies to the ONPP pharmacy team for review. And if we really haven't had an incident yet, but in the case where the MCEs disagree with ONPP pharmacy team's review directions, the ONPP pharmacy team will present their criteria to the board for a final determination. So that you're aware, the ONPP pharmacy team does not oversee MCE channel management programs. We've not ever done that, and we don't now, so they can channel manage away. Okay, the last slide is the ONPP pharmacy team submits that all 3 MCE pathways pharmacy benefits meet their legal requirements and requests the board approves their formularies. Any questions?
Hey, John, this is Chris. Question about the fact that the MCEs can have differences in the way they adjudicate claims either through pharmacy benefit or medical benefit. Do you anticipate any confusions within provider communities?
We have been working with the MCEs since 2015, and I would say that I've only had 1 or 2 instances in the past where we have had to kind of discuss things with an MCE or 2 about a creative program that they wanted to implement. Otherwise, we have had absolutely no problems with their channel management. And I'll be honest with you, in some ways, we have adopted some of that on our end, on the fee-for-service end. So I would say, no, we don't anticipate any issues. And if there are any issues that are raised to our attention, we have a very good relationship with our MC pharmacy partners and will always work to resolve those issues.
And second question, just to tie into that, there are differences in reimbursement rates between medical benefit versus pharmacy benefit. Are those considerations given in the statement that the programs should not increase costs how they manage the pharmacy benefit?
So we don't review exactly how much they are paying out. Obviously, from the SUPDL standpoint, they have to follow our SUPDL. So from the financial standpoint there, that's not an issue. And we are also moving to implement SUPDL on the medical side in fee-for-service land as well, which the MCEs are already doing. So we would not anticipate that there would be any financial issues with how they manage, because it's in their best interest to keep their costs low. And so we wouldn't anticipate they would be doing something of a large scale that would increase their costs.
Okay, and just one last question. So the contracts for all the MCs, they're at risk on the cost of the programs themselves, right? There's no pass through on any of the costs.
To my knowledge, there aren't any pass-through costs, and I don't know. That one does not stick out. And I know from the past one, actually, when we were starting to look at in 2014 and 2015, the HIP program, and if there was a need to do such a thing, and we chose not to, and actually you should recall that when you were here, because you were here, but, and we have not done anything or made any changes to that particular part of the contracts.
Okay, thank you.
You're welcome. You guys follow the dollar amounts or just, yeah. And I'll just throw this in, they do follow the fee schedule, the fee-for-service fee schedule from the standpoint of all the requirements, not the dollar amounts that are listed there, but everything else they do follow. So if it's listed on the fee schedule, they cover it, and if it's not, they don't.
Okay, so they all adopt the Medicaid fee schedule for the medical?
Yes, yep. Just
okay,
not
thank
the
you.
dollar amount.
Motion to approve.
This is Chris, I approve.
True, second.
All right, we have a motion and a second. Dr. Ott,
Aye.
Dr. Klaas,
Aye.
Ms. Fippen,
Aye.
Mr. Johnson,
Yes.
Dr. Simon,
Aye.
and Dr. Treadwell.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. Russ.
Thank you.
Okay, just let me know what you think.
All right, we will go on to new drugs then. I do have some new drugs to present today. So you did receive a hemophilia B agents PA update. These are for the gene therapies. So the new drug is Becfez, and the criteria is they must meet all of the following: diagnosis of congenital factor 9 deficiency, which is hemophilia B, classified as moderate to severe, as defined by circulating factor 9 levels less than 2 international units per deciliter, or less than or equal to 2% of normal. And then one of the following for documentation that the member currently requires factor IX prophylaxis. The member currently has or had, how is that worded? Has had, thank you. I don't know how to speak today. Life-threatening hemorrhage. The member has experienced 2 or more spontaneous bleeding episodes that required hospitalization or intervention. They need to be 18 years of age or older, should be prescribed by or in consultation with a hematologist qualified to administer Becfez from a qualified treatment center. And then they need to submit laboratory documentation, and this is around safety, so assessment of liver fibrosis, indicating that they're negative for serologic evidence of hepatitis B or C, and then laboratory testing around HIV and that the HIV is adequately controlled. And then the member is negative for neutralizing antibodies to adeno-associated virus serotype RH74BAR, capsid as detected by the FDA approved test. And then exclusion therapy would be any prior gene therapy treatment. Any questions on Becfez? Not, I'll move on to the next. In the non-SUPDL agents, we have a new mycophenolate suspension, myhibin. And their criteria is going to be must be under the age of 12 years of age, or members 12 years of age and older and unable to swallow the capsule tablet formulation. And then in the pulmonary antihypertensives agent PA, there's updating product indication throughout to explicitly state pulmonary arterial hypertension. It was just previously listed as pulmonary hypertension. And we do have a couple of new products in the pulmonary antihypertensives PA. So Opsynvi is a new combination product of Opsumit and Tadalafil. We're recommending adding it to non-preferred with drug-specific PA, that they have a diagnosis of pulmonary arterial hypertension. It's prescribed by or in consultation with a pulmonologist or cardiologist, and they should have a previous trial and failure of the separate components for use, or that the prescriber has provided rationale as to why they have to use the combination therapy. The requested dose does not exceed 10 milligrams per 40 milligrams per day. And then those of childbearing potential need to submit a negative pregnancy test within the past 30 days. And then there is a REMS program for this product for female members, so they need to participate in that program. And then as far as drug interactions go, they shouldn't have a recent claim for nitrate therapy, PDE5 inhibitors other than the one being requested, and is it Riociguat? I think it's Riociguat. We're going with that. And then reauthorization is history of requested agent for at least 60 days within the past 90. Again, same dose, and that they haven't added any of those drug interaction claims to this therapy. And then brand new therapy, Winrevair, recommending adding to non-preferred. Again, similar criteria around having the diagnosis of pulmonary arterial hypertension prescribed by or in consultation with a pulmonologist or cardiologist. They need to be 18 years of age or older. And then they should have a previous trial and failure of at least 60 days of therapy with any agent from 2 of the following subcategories. You can see all the subcategories there. It's within the pulmonary arterial hypertension drugs. Their studies did include them utilizing those therapies at the same time, so they could either utilize or not utilize. And then prescriber has provided medical justification for the use of Winrevair over the other agents. And then they should have obtained a baseline hemoglobin and platelet count prior to initiating therapy, and their baseline platelet count should be above 50,000 or greater, and that the prescriber is going to continue to monitor these things for safety. And then the requested dose does not exceed 0.7 milligrams per kilogram of their actual body weight every 3 weeks. Reauthorization criteria is history of the requested agent for 60 days within the past 90 days. And then prescribers submitted documentation that they are supporting either improvement or stabilization of the disease state. And then again, the same requested dose. You may wonder why we have the criteria in around supporting improvement or stabilization of the disease state. This is the first agent that's out that truly modifies the disease and can improve the disease. So that's why we're looking at that versus kind of just the others are a little more band-aiding the situation. So we're wanting to see that they are actually getting benefit from the therapy. Any questions on any of the new drugs? If not, if
Hey,
I could get a
Amanda,
motion.
Amanda, this is Chris. I do have a question on the Becvez. Is the Becvez administered in an inpatient setting likely? Is approval of Becvez from the pharmacy essentially would be considered approval for the treatment in an inpatient setting?
So it could be administered in an inpatient setting, but it is not, it can be administered on an outpatient basis. I know some of the other gene therapies do require inpatient situations, but Becvez and its sister product Hemgenix would not. So that could be administered in an outpatient setting.
But they have to be approved through they have to, it's not just like anybody outpatient can do it. They have to be an approved treatment center to administer.
That is, thanks. Thank you.
So would there be a separate approval process for that treatment or just?
So what we will do is if and when Becvez gets a drug-specific HCPCS code, we would consider adding it to the medical benefit. And we will use the criteria that you've approved for it here when we announce its coverage on the medical side. Any questions?
No, I just, there are other concerns, but the centers are going to have to deal with the handling of that particular product with the potential transfer or contamination of other people using the medication. So
That's why only given in select centers.
Right, those who have treatment approved centers, they understand the appropriate handling and all of that they need to do.
And Amanda, maybe you know this, I don't know this, but given that members may be shedding some of this over up to 6 months of treatment, shedding this medication, is there any environmental risks?
So I would say that actually there are some precautions around intimate contact in the labeling, but the labeling doesn't go much further than that. We have opted not to get at that level of the weeds in our criteria. We're going to assume that these facilities and these providers can have enough knowledge to adequately educate their patients as it's being administered and after. So other than that, coughing or sneezing, to my knowledge, would not be something that would pass along a hemophilia B vector.
Yeah, interesting product.
Very. Yeah.
Sorry, I'm just doing some really quick light reading to see if it just says to instruct caregivers to use proper hand hygiene in coming in contact with secretions or excretions, or if they have like if they're handling urine or feces, that kind of anything that would be coming from the patient, but it doesn't sound like there's much further concern than that. And it says for 6 months, after the procedure that they need to, but again,
the biggest concern, Amanda, is the potential excretion risk into the water supply, right? Is there ways to filter it out once it gets into the water supply?
It says they're supposed to, so there is actual procedures that they have to where they should be using sealed bags to dispose of their bodily waste for 6 months is what it lists in here. Now, I'm assuming that all the prescribers are aware and do what they need to do as a part of that treatment. As we know that, if people are being having their thyroid irradiated or whatever, they have procedures they have to follow. It would be similar things. So that's what it says that they're supposed to follow. Is potentially everybody doing exactly that for 6 months without anybody tracking? Unknown, but that is the recommendation.
Yeah, 6 months is a long time to be bagging everything, right?
Yeah, and I don't know that there's a whole lot we can, short of having somebody in a facility for 6 months and having somebody, manually do it for them, that we can be assured that they're actually doing that.
Once they receive the product, we don't have a whole lot of control. I will also say that Hemgenics has been on the market for over a year now, and we've not had one request yet. So. Interesting.
Any other questions we can answer or try and search up? Because I don't know off the top of my head. If not, if we could get a motion and a second, please, for the new drugs, I would appreciate it.
This is Chris, a motion to approve.
Is there a second?
All right, so we have a motion and a second. Dr. Ott.
Aye.
Dr. Klaas.
Aye.
Ms. Fippen.
Aye.
Mr. Johnson.
Yes.
Dr. Simon.
Aye.
Dr. Treadwell.
Aye.
All right, we have all ayes, so that motion will carry. Thank you. Any liaisons with other boards today? All right, I'm hearing none. So we will move on then to public comment. No public comment in the room, but let me check the chat. So it looks like Lisa Wright, she's going to get back time, so we're good there. Any other public comment? You can shoot a message in the chat box, raise your hand. All right, I'm hearing and seeing none there, so we'll move on to old business. Any old business? Also hearing and seeing none, so we'll move on to new business. Any new business before I cover mine from the board? All right. I will go on to mine then. So we did update the Hemgenics PA just to match more of the BECVEZ. So for the Hemgenics, we're now not just going to call it Hemgenics, we're going to call it the Hemophilia B Agents PA since we have more than one. And then update the negative test results for all of the following to the following. So we've got then the laboratory test indicating the member has no adeno-associated vector serotype 5, the laboratory testing that the member is negative for factor 9 inhibitors, negative for serologic evidence of Hep B and C, and then around the HIV and the liver fibrosis score, and then all other criteria would be maintained. So just making that consistent throughout for both agents. And then continuing on with our new business, we do have some updates around removing age limits from some agents, and you may be wondering why we are doing that. And we have had some situations of late where, because there's an age limit in place, and if there's not an approved indication or approved compendia indication, we're not permitted via reg to reimburse for those products. The problem where this has come to be is that historically we had pharmacies that would compound these agents, but now that they're commercially available, they will not compound due to that guidance. So I know that Mr. Ross has reached out to the FDA. I've reached out to CMS. I think he's also reached out to CMS.
And the Board of Pharmacy here.
Yeah, and talking to the Board of Pharmacy and a whole host of individuals that we can try and loop in to basically say, you know, this FDA guidance around compounding really restricts pharmacies, and we get in a situation where there's plenty of literature and guidelines that suggest the utilization of a product in a certain age group, But because of the way the reg is written, we don't have a lot of wiggle room around that. And so we've asked for the guidance to be updated to demonstrate that if it's not an approved compendia, that they could still compound if it doesn't have that indication. I know Mr. Ross talked to the FDA about why are you approving things with these indications like this? Because you're putting us in a position where people are going to go without treatment. And so unfortunately, nobody has given any kind of insight or guidance or discussion on what to do with the situation, and it is something that all of the states are facing. So one of the decisions that we've decided to do here is to just remove the age edit to try and prevent us from having to be in a situation where we're not going to be reimbursed for something that we know there's plenty of data to suggest that we should. So in the cases here, so for the Carasphere and the indomethacin suspension, removing the age limit but maintaining the inability to swallow criteria. For the proton pump inhibitors, for the ComboMep and the Zegerid, removing the age limit but maintaining the step edit and criteria that's in place on the non-preferred side. And then several baclofen, so the baclofen solutions and the Flexuvi suspension, removing their age limit by maintaining the trial and failure of Levispa packets, and then Levispa just removing the age limit and maintaining the inability to swallow. Norlicva removing the age edit and maintaining its inability to swallow edit, and then the Valsartan solution removing the age and maintaining its inability to swallow edit. There may be more to come on this as we try and decipher new ways to navigate this, because obviously we don't want just everybody using some of these products as they're way more costly if they can swallow the available tablet or capsule formulations, but we want to make sure that those that really need it are able to access it. Any questions on that piece and why we're taking that approach? All right. And then for the preferred brand drug updates, for implementation additions, adding the Emflaza suspension to the brand preferred list, and then removals, Renagel 800 milligram tablets. And then these removals were effective immediately, the Elidil and the Vimovo, just because they are no longer available. And so we want to make sure that patients can access that. Any questions on any of the new business? If not, if I could get a motion in a second, please.
Ms. Chris,
This
approve.
is Pat, move to approve.
Second.
I'll take you both. I got you. All right, we have a motion and a second. Dr. Ott.
Aye.
Dr. Klass.
Aye.
Ms. Fippen.
Aye.
Mr. Johnson.
Yes.
Dr. Simon.
Aye.
And Dr. Treadwell.
Aye.
All right, we have all ayes, so that motion carries. Thank you. Any other new business before we go to our last agenda item? All right, Dr. Ott takes us to adjournment.
Move to adjourn.
Have a great weekend, everybody. Thanks so much for your time.
Thanks.
Stay cool.
Bye.
Bye.